Hello, good day to everyone. My name is C.B. Mamaril, and on behalf of the Systems for Action National Coordinating Center, I'd like to welcome all of you to today's Systems for Action Research and Progress webinar on strategies to achieve alignment, collaboration, and synergy across delivery and financing systems. We're excited to have with us today a research team from one of our latest cohort of S4A research grantees. We'll be presenting on testing a new terminology system for health and social services integration. Before we get started, I'd like to first acknowledge the funding and support of the Robert Wood Johnson Foundation. Systems for Action is a national program office of the Robert Wood Johnson Foundation and a collaborative effort of the Center for Public Health Systems and Services Research in the College of Public Health and the Center for Poverty Research in the Gatton College of Business and Economics, administered by the University of Kentucky. And I'd also like to encourage everyone that if you have any questions during the presentation, please feel free to type in your questions in the chat box that's located in the lower left-hand corner of your screen, and we'll try to get to those questions at the end of the presentation. So with that, it is my pleasure to present and introduce to you first our presenters and our commentary speaker for today's webinar, starting with Dr. Miriam Laugesen, who is author of Fixing Medical Prices, How Physicians Are Paid. She's a nationally recognized expert on physician payment. Miriam is a TOE Foundation Faculty Scholar, which is an award provided in recognition of outstanding and innovative research and thought leadership by mid-career faculty at the Mailman School of Public Health. Miriam is also a past Public Voices Fellow in the Op-Ed Project's Columbia University's cohort from 2015 to 2016, and she's also a past recipient of a Robert Wood Johnson Foundation Investigator Award in Health Policy Research. Miriam serves on a number of journal editorial boards and is currently the book review editor for the Journal of Health Politics, Policy, and Law, which is the foremost journal addressing the intersection of politics, law, and health policy. Our other presenter for today is Dr. Sara Abiola, who graduated from Harvard University's Interfaculty PhD program in health policy, and she's also a Harvard Law School graduate. She worked as a postdoctoral research fellow in the Department of Health Policy and Management at Harvard T.H. Chan School of Public Health and the Center for Community-Based Research at the Dana-Farber Cancer Institute, the Civil Rights Project at Harvard University, and the Charles Hamilton Institute for Race and Justice at Harvard Law School. Sara is a recipient of the Harvard Graduate Prize Fellowship and has also received Harvard University Certificate of Distinction in Teaching for outstanding instruction on inequalities in healthcare. Her research focuses on the effects of public health laws on population health with an emphasis on food policy, obesity, and non-communicable diseases. She has also co-authored publications on these topics and others in the New England Journal of Medicine, Health Affairs, and the Journal of Law, Medicine, and Ethics, and has contributed to public health conversations on NPR Radio and Vox. Our commentary speaker for today is Dr. Harold Pollack, who is the Helen Ross Professor at the School of Social Service Administration. He is also an affiliate professor in the Biological Sciences Collegiate Division and the Department of Public Health Sciences. He is co-director of the University of Chicago Crime Lab and a committee member of the Center for Health Administration Studies at the University of Chicago. Harold has published widely at the interface between poverty policy and public health. His research appears in such journals as Addiction, Journal of the American Medical Association, American Journal of Public Health, Health Services Research, Pediatrics, and Social Service Review. A 2012 to 2014 Robert Wood Johnson Investigator in Health Policy Research, Harold has been appointed to 3 committees of the National Academy of Sciences. Before coming to SSA, Harold was a Robert Wood Johnson Foundation Scholar in Health Policy Research at Yale and taught health management policy at the University of Michigan School of Public Health. His writings have appeared in Washington Post, The Nation, The New York Times, New Republic, and other popular publications. So with that, I'd like to turn it over to our presenters, Miriam and Sara.
Hello, everyone. Welcome, and thank you for joining us today. Thanks also to the S4 team, especially Cara Richardson, and thanks CB and Harold for joining us. So we're very excited. We talked to you last month about our project, so if you weren't able to join us, we're definitely going to walk you through what we're doing. But this time we're going to be talking more about our findings and some of the things that that we've been working on and preliminary results. So currently we've got this issue in the healthcare system, which is that social services are kind of siloed and they're separated from the health system. This creates barriers to addressing the social determinants of health. And so our project is focused on this issue of linking those two sectors. One of the things one of the reasons why we got started on this project was, our background in medical services and legal interventions. One of the things that I explored in my book was the fact that, coding is a really important part of the health policy system that, doesn't get a lot of attention. Medical services are really, really well defined, and there's an established process for sort of describing what a medical service is. And a lot of that has to do with the history of medicine and the trust that we put in professionals and the early development of the profession of medicine, which gave doctors a sort of a domain that was fairly well defined. That has created a set of institutions which defines and codifies services. It gives services codes, numbers that can be used in the processing of claims. In contrast, professions like social workers have very little representation or even a voice in the process of saying, this is what our services are, this is what we do, and can we have it reimbursed by insurers? So there's that side of it, which is the medical side, is sort of dominant. Lastly, I think that there's a lot of innovation going on, and we certainly were surprised at how much innovation was going on at the state level. However, that creates its own issues with trying to get some sort of national view of what's going on and what is the state of play at the national level. So what we're trying to do is develop a reimbursement system that facilitates access to social services through the medical system that will address the social determinants of health. There's three aims to the project, and I think that this leverages our skills in law and policy. One of the major focuses of the project is looking at the laws around Medicare and Medicaid reimbursement. And that is complex. It's definitely not a simple thing to wrap your arms around. In addition, and this speaks to the lack of sectoral collaboration, the non-medical services that are reimbursed by private insurers, it's unclear, or it was unclear when we started, how to access the knowledge on this topic. So Sarah's going to speak about this area of the project.
Great. So the kind of key consideration when attempting to address the first aim was to really get our hands around the scope of laws and regulations, because it's a combination of the two that really speak to how we're able to provide social services through the context of a medical billing infrastructure, as Miriam suggested. So we had quite a task ahead of us, and we had to pull from a variety of different resources to try to put together a landscape, if you will, a legal landscape, a roadmap of how to get from kind of a medical model to a model of providing coverage of non-clinical, non-medical services that have implications for the social determinants of health. So in order to do that, we did quite a bit of background research using very specific legislative databases, court dockets, court opinions, legal analyses of certain types of medical reimbursement codes, legal portfolios, codified statutes and regulations, regulatory and administrative rules, as well as the guidance and interpretation that goes along with those. Later on in the presentation, we'll try to specify how each of these elements has really played into the conversation around how we currently think about a billing terminology or a system for integrated medical and social services, and highlight those areas that have been particularly successful, that have been adopted by states at greater rates. So, for example, the model of community health workers provides a great kind of ground, a great kind of foundation for looking at how these laws and regulations are playing out on the ground. And of course, we also want to consider how private payers are folded into this system of providing reimbursement or covering the costs associated with social services, housing, education, transportation, and any number of non-clinical services. So we'll talk about the findings in relation to that as well.
A key part of the project is looking at the delivery and financing system and the integration of care. And we really need developing a set of principles that will guide this kind of integration. It's really a very big question to organize and try and find a system for integrating these sectors. And part of that is figuring out what the new system, or what a system what that would look like. So the methods and the data sources for this are also diverse, just as Sara was describing with the legal context, and it involves quite a bit of detective work in terms of understanding, how is this done, because there's no kind of template for what we're doing, there's no model for what we're doing. We are figuring out the integration of sectors that do not talk to each other, really have very little idea of what the other sectors are doing. So there's sort of real problems that we discovered in terms of the lack of communication, which is perfectly understandable. Everybody is working in their sort of area. So we are talking to a wide variety of organizations, but there's not much crossover between them. The last aim is focused on talking to stakeholders and getting some kind of engagement around the issue of reimbursing social services through the medical system. This is a challenging task as well, but I think that engaging the sector is really important, and ultimately, it requires engagement in order to be successful. For the Aim 3, we are conducting interviews, and we've talked to a wide variety of stakeholders and canvassed their opinions. Those conversations have been really useful. Sometimes they've been difficult as well because of this more sectoral, single, siloed way of thinking. It's hard to sometimes engage people in thinking about, unifying those disparate areas. So now we're going to talk about our findings. Sara will come back to the legal mechanisms.
Excellent. So here what we're trying to do is kind of give a sense for where in the law that we currently have on the books can we find examples of or language of integration that speaks to the ability of the medical model to pay for non-medical, non-clinical services. So the first kind of section that is relevant to this and that provides quite a bit of information for us is Title V of the ACA. So of course, the ACA did many things that were innovative at the time that it was passed, but there was also quite a bit of language in there that spoke to the notion of prevention. And in this context, prevention really is moving us in the direction of trying to address some of the social determinants of health. So there were a few different mechanisms, and we'll see that these kind of overlap with the notion of financing in ways that speak to the issue of billing and coding. They speak to how we can actually pay for these services. So the first section, 5102, Obviously, it's a grant mechanism, and it allows for comprehensive planning to carry out activities leading to coherent and comprehensive healthcare workforce development strategies. This notion of developing a kind of new workforce is really at the heart of trying to find out ways to pay for actors within the community, such as social workers, those who are kind of non-licensed health providers, other people who are involved in the process of providing assistance to the community in meaningful ways, how to bring them into the fold of kind of individuals that would be considered practitioners that could be reimbursed under some sort of medical model. So that's Section 5102. It's kind of critical to the conversation. 5313, again, a funding mechanism, but it's linked to trying to promote the availability of different types of health providers to certain populations. So again, we see this kind of overlap in the law between kind of a financing mechanism as well as a provision of a non-clinical community-based services, usually linked to the Medicaid population. And then finally, we can see the notion of trying to really encourage demonstration projects that we're going to bring members of the community into healthcare professions, and in doing so, creating space to find ways to pay for the types of services that these perhaps non-traditional, kind of non-licensed providers would be able to give to these communities. Perhaps the biggest example of this expansion, and we're going to talk about this one at length when we talk about community health workers, is Section 1115 of the Social Security Act, which is distinct from the ACA, and it's really focused almost exclusively on Medicaid demonstration waivers. So here we see an explicit call to provide states with the opportunity to craft projects that are informed by their local circumstance that really will move care beyond routine medical care and to test evidence-based interventions that improve health outcomes and quality of life. So we'll see in just a moment how some states have used that Section 1115, the Medicaid waiver mechanism, to finance new strategies to address social determinants of health, and more specifically how they've used that to scale up access to community health workers. So on the next slide, we see kind of ongoing movements in kind of various capacities at the state level again to really incorporate managed care organizations. So one of the things that was fascinating to us and that really speaks to this notion of trying to bring together not just the public payer but also private payers has to do with kind of creating a space for MCOs to determine what types of services, non-clinical services or social support services as they're called in the language of the legislation, how they can go about bringing those types of services into the fold. So MCOs do have a great deal of flexibility to cover additional social services that don't appear in the kind of approved state Medicaid plans. However, there is a process that they have to go through in order to be able to continue to offer or to be able to kind of offer in general what were considered to be these value-added services. So they do have to demonstrate that there is a cost-effectiveness component to these services, and they are in fact improving health outcomes in certain communities. And once they're able to make that demonstration to the state's satisfaction, the cost of these value-added services are in fact rolled into the administrative portion of the rate that they receive for those types of services. There is some variability in that, I should note, in the sense that in some instances, the cost of the value-added services can be moved over to the kind of medical portion of the rate as opposed to being kind of paid through the administrative portion. But that, again, kind of varies by plan, varies by state. So we're trying to kind of weave a coherent story, but there's quite a bit of variation. But it should be pointed out that MCOs do have the capacity to include value-added service if they're able to work effectively with the state Medicaid agency. And then finally, we'll see in just a moment that there is a significant amount of government funding, or there was prior to the change in administration, for government funding for innovative payment and service delivery models. So this is kind of seen coming most frequently through the CMS Innovation Center, and as a result of that, they kind of rolled out 3 different models that states have been able to kind of play with over the past few years in terms of figuring out how they want to deal with social determinants. The accountable health communities, healthcare innovation, and the state innovation models. Again, with the state innovation model perhaps being one that we'll talk about at greater length, because this is the state's effort to bring multiple payers into a system that allows them to offer value-added services or non-clinical services or non-traditional services. I'm using these various terms to highlight the fact that different kind of STEM models have different type of language to capture this notion of covering these social support services. And they can, of course, extend these even beyond Medicaid beneficiaries, which is really important to us. So finally, and this is kind of to highlight Miriam's point about variation, we have a couple of images here to kind of give us a sense for how big this particular kind of problem of bringing in non-traditional providers is and how aggressive states have been in attempting to address it. And here we see a map that kind of shows how many states have had some sort of action in relation to state community health workers. And as we can see, which is perhaps reassuring on its surface, that the majority of states, in fact the overwhelming majority, have in fact adopted some form of intervention to address the availability of community health workers. However, what's obscured by this kind of sea of green is the degree of variation there is across states in terms of how they've been able to harmonize the financing mechanism, which is really at the heart of our kind of inquiry here. Once we lay out the legal landscape, Miriam is going to talk more about the coding behind this, but everyone is doing something, but they're all doing something a little bit different. So we're going to talk about that for just a moment and then get into the actual coding of it, which is quite fascinating once you kind of get into the details of it. So on the next slide, kind of digging a little bit into this notion of community health worker models, we're going to look at the financing quickly for just a small sample of states. So this really just talks about the northeastern region of the country, and even in this kind of geographic kind of community, right, whereby we know the kind of policy diffusion would suggest that we might see some similar types of efforts across states that are close to each other, we don't really see that coherence in this particular area. So the financing mechanisms, if you go through, they do touch on the pieces of legislation that we just looked at. So you can see some folks have used the Section 1115 demonstrations. New Hampshire, for example, has done that. You can see states like Pennsylvania are using their managed care organizations. You can see that other states like Rhode Island and Maryland are relying on that grant funding that we discussed. They're kind of using different variations of that. And some states are using their kind of STEM models, kind of state innovation models to pay for their community health workers. But what's also key to point out is that if we just look at the column furthest to the right, does Medicaid reimburse for these community health worker services? And that answer is not always consistent across states, even if they're using similar financing mechanisms. So this notion of kind of making sure that non-clinical providers or non-traditional providers are reimbursed through the medical model is not one that has necessarily gained kind of traction across the board, even if there's general acceptance or general notions that we can finance it. And so we'll talk a little bit more about how there are kind of certain barriers that are built into the language of these different types of regulations that might make this leap difficult, even for something as popular as the community health workers model. So in that regard, we're going to kind of talk a little bit more about Medicare coverage and link that to some of the kind of patterns that we've just noticed.
I'm just going to jump in and talk about Medicare. That's something that obviously, I've done a lot of work on, and the professional distinctions are very interesting. When you think about what Medicare reimburses for, it's very much driven by the 1965 legislative base, and that really focuses on medical services. Not surprisingly, it's a health insurance program. However, this has not really sort of kept up with the expansion of other professions. And so, for example, social workers, are sharply limited in terms of what they're able to work on. If they work within an institution, sometimes there's restrictions on reimbursement, separate reimbursement. Overall, Medicare, which sets the agenda for many private payers, is lacking that kind of flexibility for reimbursement of other professions. In terms of Medicaid, as said, there is the waiver system, and this has a number of strengths, including the wraparound component, the very flexible ability of states to be very flexible in terms of how they manage their programs. But there are weaknesses, and one of them is obviously the federal, the role of the federal government as funder, puts constraints on that. In addition, it's not so much necessarily targeted towards most enrollees or most people in the programs. It's usually more limited in terms of people who are the most vulnerable populations. So while it's good that those populations are being helped, expanding it beyond a smaller group is really important for if this model is going to be more widely adopted. With the managed care plans, there's also a question as to how that works within the managed care plans, and there's a little bit of opacity with that regard. Overall, I think what we've learned is that there is a tendency to think about this social service component of healthcare as being about integration. So what that tends to mean is actual sort of physical integration of teams and professions. So rather than thinking about necessarily the financing across the board, there's been more of a focus on integrating, and that's the key word, integrating care. And that ranges from having care management at one end, which is being called the more low-touch kind of approach, all the way to this kind of physical co-location and integration within the delivery system. Those are great models. However, as said, there's not a sort of a consistent policy across payers. And let me give you an example of one consistent policy across payers that really sort of changed the landscape within cancer was cancer screening. Now, mandates were introduced at the state level and then finally at the federal level to cover those services. Over time, those preventive services became entrenched into our health insurance system, even in the private sector, and were included in the ACA. So the issue of what is covered and how, and who has to follow those laws and regulations is really important, but there has to be some kind of universality of those approaches for them to really gain traction. The issue of co-location requires major shifts. So in our fee-for-service system, changing the physical location in order to integrate poses a lot of logistical challenges and upfront costs. Another way to integrate is to simply provide payment reform incentives, and to encourage value-based payments by unifying teams of providers. That is dependent, as we all know, on what the federal policy context looks like. It also requires a commitment that's long-term. So if you're going to shift the delivery system and you're a provider and you want to do this, you need to know that it's going to be there, that the investment that you're making is going to work. And what we see in payment reform policies is a lot of change, from year to year, a lot of adaptations of what seems like a policy that's been decided. Often, if you look at MACRA, for example, there's been just a huge number of changes. So you can't really rely on it as a provider to be consistent across time necessarily. Again, coming back to this issue of payer-specific policies, this doesn't allow for a seamless integration. Let me just get into what are called the HCPCS codes. Now, many of you will know this coding system, but just to explain briefly, these are, the backbone of our billing system, and the codes are divided into physician, which is a huge number of codes, and non-physician services. And then there's a whole lot of other distinctions within that, everything from DME to medical supplies. What happens with these codes is they're determined by CMS, and there's a lot of input by different stakeholders into this, and this is a key focus for what we're looking at because, as Sarah said, it's all about the coding, and it's a very interesting area. So we found that there was this option available that we haven't found a widespread sort of adoption or knowledge of these codes, but they are there. They're sort of lurking in the background, waiting to be used. And these are the T codes. So T codes are essentially social services codes. They are specific to Medicaid, and as said, they are, however, sort of a very well-kept secret. So the T codes offer a number of defined social services, and this is the kind of thing that I think is really, really helpful because they lay out the parameters of social services, and here's some examples. We also found that there were another set of codes called H codes, and these are also available for use but focused on substance abuse. In talking to stakeholders, and we can talk about this more in the questions section, and I've just got, I'm just going to have this slide and then one more. We found that, again, there was a separation between the different sectors, and everybody supports and is on board with the idea of social determinants, but there's a lack of agreement on what that means. There is this opportunity to leverage the opioid epidemic to really expand what is being done, what has been done, and there's a lot of political support for that. But we're also lacking a sort of a common language to talk about financing social services, and that's a key thing. You need to be able to communicate across sectors. One of the important lessons of Medicare is that even though it is a program for the disabled and the elderly, it really sets the tone for the whole healthcare system. So when Medicare adopted ACOs, that became kind of almost began to become an industry standard. The Medicaid programs provide enormous potential, but there needs to be a sort of a translation of what's happening more into the other sectors. And obviously you can't necessarily match Medicaid's coverage in Medicare or even private insurers, but maybe there's elements of it that can be adapted and adopted. I'm going to put these questions up here. Sarah and I would be really interested in hearing from you about some of these issues and your perspective, where you sit and how you think about some of these ideas. But I'm going to hand it over now to our moderator and our discussant. Thank you.
Thank you, Miriam, and thank you, Sarah. Before I turn it over to Harold, I just wanted to remind everyone that if you have questions, please do type in your questions in the chat box in the lower left corner of your screen, and we'll try to get them to you. We'll try to get to them at the end of the commentary. We also want to let you know that also this presentation is also available later on our Systems for Action website too as well. So again, please do type in your questions if you have any questions. And with that, I'd like to turn it over to you, Harold, for your commentary.
Thanks so much. It's wonderful to comment on this really outstanding project done by a team that I have just huge respect for, and the complexity of the different types of data and documents and administrative regulations that you had to navigate in this project is something that is very difficult for an outsider to fully appreciate. You know, when you think about the complexity of reimbursement policy, of Medicare and Medicaid rules, state waiver applications, it's really it's very intimidating, and the complexity of it is not just kind of an annoying aspect of what you have to do to research it. It's inherent to the enterprise, and all the stakeholders in these systems are just facing a bewildering complexity that is, that's just a major constraint on everybody. Some points that I just wanted to raise from the presentation. One is, it is striking that Medicaid is the principal and very diverse set of platforms that we're really trying to use to address the social determinants of health. And many of the things that we often talk about in policy as shortcomings of Medicaid are really a reflection of the fact that Medicaid is trying to struggle with the set of social challenges, epidemiological challenges, political challenges, the challenges of federalism that are that are just very fundamental as we try to find better ways to help individuals, families, and communities. Medicare is quite a leader in many aspects of healthcare delivery innovation, but not so much in dealing with the complexity of the social determinants. And particularly since so many of the people we're most concerned about are actually dual eligible, Medicare and Medicaid, that's a real challenge. One point that I wanted to reiterate that you made is concerns the opioid epidemic. And in many ways, this is a remarkable test case for Medicaid. And we've been, as part of the National Drug Abuse Treatment System Survey, Christina Andrews and Colleen Grogan and I and Cliff Bursamir and a number of other people, Amanda Abraham, we've been talking to stakeholders around the country about how they're trying to use Medicaid to deal with the opioid epidemic. And what's really striking is the seriousness and inventiveness that the states are bringing to this problem. Often in an unexpected way, if all you knew about American politics and health policy came from what you see in Washington. Around the states, Democratic and Republican governors are just desperate to find a way to deal with this epidemic. And many states, the Obama administration, the Trump administration, are trying to bring their A game to this problem in a very real way. And I remember talking to one state addiction director and asking him, it was right in the middle of the fight to repeal the Affordable Care Act, and I asked him, what's going on with, how are you thinking about the uncertainties in Washington? And he said, my governor has told me not to worry about any of that stuff. What my job is to figure out how to actually take better care of people and to design a Medicaid waiver that would address the kinds of problems that you just heard about. And I found it kind of inspiring. It happened to be a Republican governor, and not someone that one might have assumed is passionately committed to the Medicaid program. And it turns out that in a striking way he was. I also want to talk a little bit about the financial imbalance between the medical and social service sectors. It's quite profound, and I thought, Elizabeth Bradley and Lauren Taylor's work comparing welfare states, United States and Western Europe, is quite timely here. It turns out that the United States and many of the social democratic countries in Western Europe spend about the same on the combined package of medical and social services, but the European countries put a lot more into the social services bucket compared to the United States. And we're doing a number of RWJ-supported projects to help individuals with addiction and mental health disorders who interface with the criminal justice system. And we have many partner agencies and medical institutions. And the fish tank in one of the academic medical centers that we work with actually costs more than one of the buildings in one of our social service partners. So that gives you a sense of this disparity. And the disparity just shows up everywhere, and non-medical services become attractive simply because they're so much cheaper than what's happening in the medical sector. And that's a totally valid consideration in how we should help people, but it can also distort things. We want to use community health workers to help people in certain tasks just because they're a lot cheaper. And that's not a healthy thing when the two sectors are funded at such a different level. And I'll close out by saying my views on some of these service integration issues are actually shaped in a very personal way by my family's experience taking care of my wife's brother, Vincent, who's a Medicaid recipient and lives with an intellectual disability and has various medical challenges. And he's one of the complex dual eligibles that states are trying to help. And he probably gets $100,000 worth of medical care every year and similar amounts of services that are provided through social services and a Medicaid waiver. And we're sometimes treated as patients, we're sometimes treated as clients. We always know which is which because we're treated much better when we are treated as patients. And one thing that's striking that didn't come up in today's presentation is what we would really like to see as a family and what Vincent would like to see as a person is not just his role as a service recipient or as a patient, but as a direct partner in care. And I think that Medicaid programs need to find better ways to address social determinants by directly engaging patients and families with the social determinants that they face, not just seeing them as passive recipients of care, even within a well-integrated system. And I'll give you just one example, and then I'll shut up so other people can talk. Vincent lives in a group home near us in the community, and in many ways the story of people like him is a successful story of deinstitutionalization that is made possible by Medicaid waiver services. But in a lot of ways, even though he lives in a house, in a community, his life is not that different from what it would be if he lived in an institution. He goes to a sheltered workshop during the day where all of his workmates also live with intellectual disabilities. He has recreational opportunities that occur because a van comes to his house, picks him up, and takes him to an activity with other people with intellectual disabilities and then drops him home at night when he's done. He and his housemates are given a $60 monthly allowance, which is supposed to pay for everything from a McDonald's hamburger to a T-shirt to the copay on a dental visit or something like that. And for many of these men, that $60 is the only money they have for whatever activities they want to do to live autonomously. And many of them are quite lonely and depressed. They've outlived their primary caregivers or their family relationships. Medicare and Medicaid are spending tens or hundreds of thousands of dollars to care for them, but very little of that is provided in a way where they themselves can control what is happening. And I think one of the frontiers in addressing social determinants is really in the area of patient and client autonomy and self-direction. and providing better ways for these services to really be provided to people in a way that patients and clients can actually have real control over how these resources are used. And I think that's just one gap that I'd like to see some future work on. So with that very verbose and rambling discussion comments, I'll now yield the floor to others. Thank you very much.
Thank you, Harold. And before we turn it over to the audience for questions, I'd like to give our presenters a chance to respond to your comments. Miriam and Sara?
Thanks, Harold. That was really great. You're the perfect person to join us on this call today, and with your knowledge both of the kind of larger policy issues and your up close personal experience. So we really value your comments. I think the issue of client engagement is so important because you've got to respect people's autonomy, and in a sense, giving people the opportunity to access services without actually having to go through a sort of a process. But, if they want us to see a social worker to help them with housing, it should be the same as, them scheduling an appointment with their primary care doctor. I mean, maybe we need to think about autonomy as being, people make decisions about which services they access. So anyway, that's all. I think, Sara, did you? Yeah.
No, I just second that, Harold. I really appreciate the kind of notion of how we are trying to really weave together a tapestry from very disparate parts of our kind of state and federal regulations to create a unifying experience. And that's not our history as a country in terms of how we think about service integration. I think your point actually encompasses a lot of the questions that we've been getting online that other speakers have been sending in around how we actually think about creating this terminology. So I think we have just enough time to try to, hopefully address some of those which are speaking to this very issue of how do we actually bring services together, and have there been any successful stories of states really being able to do that?
All right, so we can get to the questions. We have about 10 minutes, so I'll tie in some of these questions since they might be related. I'll tie in Eileen, Larry, and William's question. So William comments that he has a concern that the medical CPT ICD billing system is tortuous, overbearing, and extremely complex, as well as a major contributor to waste and administrative overhead costs. Why use this dysfunctional system in your model to create a common vocabulary? Eileen asked, do you know of any existing analysis of this T and H codes? And Larry also asked, what about the concern that T-code billing could replicate the financially unsustainable, non-patient-centric characteristics of FFS medicine in FFS social care? So those three questions are sort of related.
Thanks for all the questions. We're looking at the questions, and we're, as usual, discovering things, finding people that have really useful information. So this is really a two-way street that we're benefiting from your questions a great deal. I think that there is a lack of existing analyses to address Eileen's question. There is a concern that there are compliance issues, and why don't you talk about that, Sara, in terms of the compliance issue?
Mm-hmm. So in terms of compliance, what we're kind of finding, and this is coming more so from the stakeholder interviews that we've been conducting, and as we get a chance to talk to more actors in the system, we'll have a better way of fleshing this out. But essentially, what becomes difficult is kind of having the actual documentation, the actual kind of ability to submit the types of forms, submit the types of claims that would help to bring the social services and the medical services together, right? So the kind of looking at the disparate sources of the financing kind of speaks to the kind of equally kind of treacherous terrain of trying to get reimbursement. So what often happens, especially through Medicaid, is that state Medicaid agencies are going to have their own process, right, that's going to be unique to their agency as to how you go about taking advantage of some of the more integrated prevention services, which is how Medicaid, which again tends to be or is trying to be a little bit kind of closer to the frontier of the integration models, they are trying to kind of make it easier for non-medical providers to actually submit their kind of forms to be reimbursed. But that is going to be the extent to which a social worker or a educator or a tutor or a driver, someone who's involved in transportation, the extent to which a non-clinical provider can do that is going to be dictated by kind of, number one, how aggressive the kind of state Medicaid agency has been in terms of making sure that kind of documentation is available. And then I think number two is just the kind of general awareness in terms of what types of services can be reimbursed. And number three, I'll just add to that, if the kind of clinical services are set up in such a way that they can provide a bridge between the kind of documentation requirements and the kind of less experienced non-clinical providers. So sometimes it's helpful if there's an integration of actual kind of billing practices such that the non-clinical folks can have a much easier go of it. So I'm hoping that that's kind of speaking to the question of compliance. It's really kind of more focused on, I think, making sure that those who are in a non-clinical setting have the ability to understand how they can go about accessing reimbursement.
Let me just jump in and talk about the coding kind of issue and also Larry's point about fee-for-service. I think that the complexity, as Harold said, is a major barrier to sort of changing policy sometimes. And some of the other questions posed by the audience, relate to this issue of professional dominance, and certainly in the coding area, it's mainly been dominated by the medical structure because they were there first. Essentially, they've been there for a long time in this space since the 1970s. So there's sort of a bias towards the medical model, and one person touched also on evidence and what is the evidence for medical services. Not always that high. There's a higher burden of proof for social service providers. So all of these issues are things that I think this is why these webinars are so helpful, is that we can sort of get very different perspectives. And this is one of those issues that is kind of like a Pandora's box. Once you open it, you find that there's many, many more layers that specialists, such as people, submitting comments here, can actually help us with. So we really are grateful. Back to you.
So I think you answered, Maureen and Larry's question regarding both compliance and sort of the concerns with the T-code billing. Colleen has a question. Are there success stories from Medicaid integration initiatives in states that have adopted them? What are key factors to success? In Illinois, we are currently on the cusp of initiating a home health integration process for Medicaid, and there are a lot of concerns within provider and payer organizations.
I think we're working at a sort of a cross-state perspective. I think that it's difficult, therefore, to sort of, to really sort of evaluate the success of any one particular state. I think they all provide some guidance in a sense of what's possible, but in terms of the effectiveness or success stories, that is often, often there's a lack of evaluation of those interventions, which is, which holds us back also in terms of moving forward with, innovative models. I think getting back to the evidence question.
Okay. I would agree with that. Yeah.
Sarah, you want to say?
Okay.
All right. Jenny asked a question, since your work was focusing on these governmental payers of Medicare and Medicaid. Did your research happen to look at what any of the private payers or insurance are doing to integrate social services? If so, did you find that they're taking steps to integrate social service reimbursement? Would you say they've been more or less successful than Medicare and Medicaid?
I think that private payers tend to focus on providing services that are basically mandated either by Medicare or the states. And, I worked a lot in insurance regulation before I started working on physician payment. And, you need to sort of have a certain amount of compulsion rather than encouragement to often get private payers on board with these sort of innovative models. They tend to, not be covering, if they don't, maybe some of the managed care plans, and I think Medicare Advantage is one model which, we didn't even really touch on today, but that is maybe an area where they may start to follow the initiatives of Medicare Advantage as a model of private insurer integration, because that is changing under federal regulation this year, or was proposed last year and will probably change.
Okay. So I guess related to that, Laura asks, given that the amount of state variation around reimbursement incentives for social care integration, could one improvement be to try to make state quality metrics around social service integration more accessible? She gives example of the Massachusetts Medicaid ACO as having quality metrics. Oregon's also struggling to find their own. So care to respond to her question?
That's really interesting. We hadn't really thought about quality, but I guess it relates to what we've been talking about the effectiveness also of these interventions. So quality is one side of the effectiveness. Does it work? Is it a good service? Is it well provided? I think I'd be interested in hearing more about those quality metrics. So please contact us offline with your ideas, but we're going to be copying all the questions down very, very carefully and looking at those sources that you've suggested.
And I think we have one more question from Michelle. She says there's a common perception that these medical services are based on sound evidence and that it is a lack of strong evidence that holds social services back from being paid for. So her experience is that we often hold these social services to higher standards than we do medical services because we're just more comfortable with services that are in our hands, not someone else. I'm curious to ask how important you think this gap or misunderstanding is on evidence and where you would suggest social services focus to help shift to applying the evidence in order to package social services with the healthcare system in mind.
I think that this speaks again to the cultivation of professions, and one of the issues is advocacy by the professions in relation to the services that they provide. The legitimacy of medical services didn't happen accidentally. It's been a very long and concerted effort to build the legitimacy of those services, and maybe what's missing in the social service space is an effort by those who are providing it to really prove, and I don't mean prove in the sense of effectiveness, but advocate for their inclusion in the system on an equal footing. I think nurse practitioners are really the main model in chiropractors and midwives, but in the social service space more, maybe there's a need for more advocacy by professions and providers themselves on some of these issues.
Any last words, Miriam and Sara?
Sara just had to go off and teach, but she sends her grateful thanks, and likewise, thank you very much for everyone who participated.
Yes, so thank you, Miriam and Sara. Thank you so much for your time and your presentation, for your research team and the work you're doing. We look forward to learning more. Thank you, Harold, for your time also as a commentary speaker. And thank you, everyone, for joining us at today's research webinar. Yes, thank you, Harold. And we hope you all have a good day. And please join us again for our upcoming webinars too as well. And today's webinar is also available for download in our Systems for Action website. So with that, thank you everyone again for joining us and have a great day. Farewell. Bye-bye.